Just coming up to 6 o'clock, so I'll give it a little bit more time before we get going. Just wait for guys to log in. Some usual suspects on the attendees list there. Evening, everyone. Okay, promise not to keep you too long on this nice sunny evening, so that you can enjoy the last bit of the day. We've got another fairly shortish session today. Hey Peter, good to see you again. Fairly shortish session today. Hi Natalie. Yeah, so hopefully be wrapped up in about half an hour or so. So hopefully not keep you too long. So this is day 2 of 3. If you've not done these sessions before, we did a session on Monday evening at 6 o'clock, and we do them Monday, Wednesday, and Friday. Hey, Namir, good to see you there. Yeah, Monday, Wednesday, Friday at 6, and we work our way through a case history and try to figure out what's wrong with these people. And to be honest, it's not about figuring out exactly what's wrong. It's about the process. Rather than the end result. So that's a thing that's really key. This is me, and again, apologies if you've heard this before, but I'm education director for movement therapy education. I also work with Rock Tape UK, and so I had a chat with Dan from Rock Tape, talk a little bit about that a little bit later on. And I work with Naki as well, who do the massage creams. So I'm one of the Naki European tutors as well. So I work for a couple of other companies. I'm clinic director at Movement Therapy Clinics, and I'm here in my clinic right now. There's no one else here, so and it's got the best Wi-Fi that I can find. I've had a few issues with Wi-Fi over the last couple of days at home. So yeah, here uninterrupted, nice and quiet, because no one is here. And I'm an osteopath. Before that, sports therapist, and before that, personal trainer, and now a clinical anatomist as well. So yeah, everything I've done has always been in kind of health and fitness circles. I did have a question pop up from someone about my route through from sports therapy into osteopathy and how I did it. So if you don't mind, I'm just going to do a little bit on that before we get going. So I was a PT and got bored with the old kind of I want to lose weight, tone up sort of people. I imagine that the industry is full of them still now. And got really interested in dealing with people's injuries and helping people out recover from surgery and things like that when I was working in the gym. So went down that route a little bit more, and that's why I went into sports therapy. And I kind of realized that I needed something else. I needed to do a little bit more to kind of move my career on. So I chose osteopathy over physio purely because of the osteopaths that I'd seen in the past and ones that had taught me as well. So not dismissing physiotherapy. In hindsight, it's I don't know. It's maybe a route that I could have gone down, but then maybe I wouldn't be where I am now. So it's all kind of swings and roundabouts, really. But yeah, so I did osteopathy. My degree was 5 years. I did a 5-year degree. It was supposed to be part-time. That's what they tell you at the beginning, but it's not really. And the first couple of years are part-time, and then years 3, 4, 5 are pretty full on. And so I did that. And alongside that, I did my postgrad in clinical anatomy. So that was kind of pathway I took. Somebody asked me about becoming an osteopath and how to do it, and should I do it? And I always ask the question, well, do you actually want to be an osteopath? So is that something you want to do, or do you just want to be a better therapist? And if you want to be a better therapist, then you can spend 40 grand on courses to make you a better therapist. If you want to be an osteopath, then you have to go down that route because it's a protected title. So if you're not bothered about the title, me personally, I don't see very many people, don't see many insurance people for me to need to be an osteopath, to be honest. It's I mean, yes, I can diagnose, and that was mentioned on one of the forums as well, about this being a differential diagnosis session. And effectively it is, but we know that unless you've got a protected title and you're part of a statutory body, then you're not allowed to diagnose. And there's reasons for that. It's mainly because of CPD and the management of qualifications. So I have to be on a register as an osteo, and the chiros do, and guys that are on HCPC do as well. And although there are registers for sports therapy, they're all over the place. So it's which is a real shame. If there was one register, then maybe sports therapy could go down that route as well. But I know Gary's from the STA has been fighting for it for a long time, and it's been talked about since I started 15 years ago. It's been talked about ever since then. So I don't think it's going to happen. So it all depends on where you want to go with your career. Okay, so if anybody else out there is thinking about becoming an osteo, you need to ask yourself, well, do I actually want to be one, or do I just want to be better? And if you want to be better, then there's lots of courses you can do to pick up things, but then you wouldn't be able to officially diagnose things. But what you would be able to do, which is what we're doing, is have a very, very good clinical reasoning plan. So it's near as damn it a diagnosis. You just go through this exactly the same process, but you just don't tell the patient. Yeah, so it's for you rather than for them. Whereas with osteo, physio, chiro, etc., you could write to the patient saying, I think you have this. With any other kind of therapy, you wouldn't be able to do that as part of your remit, but you could still think it. And I think you need to have those thinking skills, those reasoning skills, to be able to direct your clients or patients towards the correct pathway, which is exactly what we're doing here. So it's exactly the same process. It's just a matter of semantics. That's all. Okay. So yeah, kind of interesting question. Sorry to go on about it at the beginning, but yeah, maybe that some of you, if you are thinking of going down that route, then maybe another discussion at another time in a bit more depth. So we've been, I talked a little bit as well about our clinic was doing something to help other clinics out. And this is it. So we've come up with this thing called Stronger Together. And what we've done is we've linked up with clinics and instructors all over the UK to put in one place a list of classes that people can do, exercise classes. So things like Pilates, we've got some yoga guys, we've got kettlebell guys, we've got body weight training, we've got loads of things on there, loads of different things. And the idea is that you give the classes for free, and for you, or a small charge for an inclusion onto the page. We don't make anything out of it. We just want to spread the news about you, because now your client base is all over the world. It's not just your area now. So if you did teach exercise in a particular location, people don't have to travel to come to you now. They do it from their own home. So what I taught a class this morning, and we had someone from Australia do it. So there's opportunities now to spread what you do to loads and loads of people in it. And if we all share it amongst our own networks, then hopefully it should spread. So have a look at that. It's on our movement therapy clinics page on Facebook. It's called MTC Stronger Together. And yeah, if you want an inclusion, or you want to do any classes, just click on the buttons and you'll get sent through to the instructors. They'll contact you. Another little thing we've been doing as well, Dan and I. So Dan Lawrence from Rock Tape. We started this Monday. Had a few sound issues on Monday, but we've been talking about tendons. Dan's written a book called Lower Limb Tendinopathies, and we're going to discuss his book, and he also teaches a course on tendons as well. So we're going to do a little bit each week, again, kind of half hour, 40-minute session with a little bit of homework to do as well. So that's every Monday on at 8 o'clock. Okay, so something to look out for as well. That's on our Facebook page too. So we looked at a case history on Monday. It was a lady, and we, well, hopefully you picked out some key points and then started to create a sieve. So the plan for today, second session, is looking at objective assessment planning and what to do, the justification for your choices, and then what to do next. Okay, so that's the plan for today. So ankle or foot scenario, again, no right or wrong answers, just a hypothesis. So if you want to put anything in the chat, then that's fine, or pop it on the Facebook page, and that's good too. So we're sifting through the sieve again, all of that information from the case scenario, and we're going to work through that and see what comes out and see what the important points are. Have to say, there's been some really good analysis of this case. Yeah, you're really starting to get the hang of it after week 3. So this is the sieve, just in case you've not seen it before. I'll just share that with you there. So if you've not seen that before, just shared it so you can download that, and then you can use that on the on next week's case history. So this was Anna. And again, if it was my exam, I would go through with a highlighter all of the key points, and these are the things that I would put down. So we've got a 62-year-old woman, and I'd highlight that straight away because there are things that conditions that will be more prevalent in that kind of age range and with females. Okay, so already you should be thinking, right, what does 60-year-old women, what do they usually what can they usually suffer from? What are the usual clinical conditions that they may come in with? And immediately you should have a few things that come into your mind. So she's worked as a cleaner, she's 5'8" and she's 8 stone. So if you put that on the BMI checker on the NHS, then she's really underweight. Okay, so she's quite thin. Freely admits she drinks alcohol in vast quantities, so that's another one to highlight. And I know a few of you picked up on potential liver problems, okay, because of that. So that's really good. She's also a heavy smoker, so she's not very healthy at all, this lady. Snacking on lots of chocolate bars and sweets, okay, so that's a big clue as to for some of the things that you guys picked up as well. And you notice that she seems to hobble when she's walking, okay, so her main complaint coming in is the problem with her legs and her feet. Psychosocial wise, so on the top part of that sieve, so the psychosocial area at the top there, we've got that she's divorced, she's very stressed, and tense about all aspects of her life. So those are things that could influence the outcome of whatever it is that you plan to do with this lady, and she feels very tired all the time as well. Okay, so interesting things there. So these are the presented, or this is the presenting complaint. So both feet are painful and tingling, and Anna describes them as numb. Okay, so quite rightly, some of you guys were pointing towards some kind of either neurological disorder or some kind of blood supply issue. Okay, and we'll have a look at that in a second. Bilateral pain in the quadriceps muscles associated with weakness. Okay, so why would your muscles feel weak? Yeah, so they may be weak. So if you tested them, they're weak, and that could be because there's an injury to the muscle or the tendon. It could be that it's a muscle guarding issue. So the pain in the area is inhibiting the muscular contraction. But it could also be that the nerve impulse to the muscle isn't getting there. Okay, so we can have weakness for a number of different reasons. But then we've got this feeling as well in the feet of numbness. So numbness again can be neurological, usually neurological or blood supply. So we need to have a think about, are these two things related? So is the quads problem linked to the feet problem, or are they two separate things? Okay, but we have no idea because she's not real. But those are the kind of things you need to go through your mind. She's got a chronic low backache, which has been present intermittently since she had her children. Now she's 62, so you'd imagine that she had her children a good 30 years ago, maybe longer. So she's had lower backache for a long time. Okay, so this has been something that's been going on for a long time. So maybe some kind of degenerative condition, possibly, considering her age as well, maybe. And a few of you came up with those things, so that was good. Her symptoms in the feet have been there for the last 6 months, and then for no apparent reason, which is a red flag. And then we've got pain and weakness in the quads that's been a feature for the last 2 months. Okay, the onset seemed fairly rapid for the quads, again for no apparent reason. So she didn't fall. There was no fall from a horse this week. Nothing like that. So again, something that happens for no apparent reason is a red flag. It's a sign of some kind of progressive condition. Okay, so it's if it was a muscular problem, if you've pulled your quad and because I don't know, you tripped down the stairs and pulled a muscle, then that usually resolves in a few weeks. Yeah, it doesn't go on for months. So the fact that it's continuing for a long period of time is a bit of a flag. Okay, the lower backache seemed to start during her pregnancy with a gradual onset, and a few of you picked up that in some of your feedback on Facebook, so that was really good. So we're going to have a look into the anatomy of the region a second. I'm just going to go into this, so hopefully you can see my my anatomy man here. So we've got a problem around the quads area, yeah, so around this area here. So what I would then do is try to figure out about all of the relatable anatomy in that area. So we can add if we add some muscles on, okay, so could be iliacus, yeah, and it depends on where the problem is. Could be the adductor group, yeah. Add another layer on, and then it could be your vastus muscles, potentially. Could be rec fem, yeah. So you can start to add on the muscles and try and work out from the location. If it was an a muscular problem, then we can work out from the anatomy where it is. But there's no onset. There's no specific onset, and there is weakness, but it doesn't appear to be a muscular issue. Okay, so if we take all those away, what we can then start to do is go, right, okay, what else runs around that area? Well, the blood supply to here. Okay, so the blood supply, the femoral artery will supply all of the leg. So if we put some branches of this femoral artery on, if I just zoom in there, so you can see the branches here coming off there. Now these are going to feed all of the muscles of the thigh. So it's a bit like a plumbing system. So if you have a blockage up here, or there's a narrowing of the lumen of the artery, that is going to affect the blood supply to the leg. Okay, so any problem up here, any problem here. If it was up here, then it may affect both legs. Okay, but because and with our patient, it is down both sides. So we're thinking, right, maybe it's something to do with a little bit higher up. Maybe it's around this descending abdominal aorta area. So she may have an issue with her blood supply just before it splits into the iliac arteries. Okay, so again, you kind of track it back, and it's a bit like it's a bit like pipe work in a house. So if you've got a blockage somewhere, it's going to affect the pipe work to the rest of that that is supplied by that pipe. So that could be an issue, and it kind of links in to what she's been saying as well. Okay, so this kind of gradual onset. So if you've got a problem with the artery, something that's been building up over time, like plaque on the inside, then that is going to slow down the blood supply to the quads over a longer period of time. Okay, so it will take some time before it has, before you start to feel it, and it will be gradually getting worse. Okay, so that's the kind of thing that it could be. And then if we go to the nervous system, so then we've got the nerve supply to this area as well. I'll just jump in there. Okay, so we've got this nerve here, which is called the femoral nerve. Yeah, exactly, Peter. Yeah. So no complaint with the calf. Yeah. So it could be an issue, but it might not be. Yeah. So that's a very good point. So that's something that would possibly rule in an arterial problem. But then you think, well, there isn't a problem with the calves, but there is a problem with the feet. Okay. So you would, because both feet are numb, even if the calves aren't, it may be that the calves are getting an adequate supply, maybe because she's not active enough to be able to feel it in the calves. And the quadriceps are quite big muscles. So if she's doing, even just walking upstairs will be quite an effort for those big muscles. So if her muscles aren't getting that perfusion of blood, then you're going to feel it in the quads before you feel it in the calves. Okay, so you're right, but it's a bit mixed. Okay, so it's still a bit of a flag. And then we've got the problem with the nerves as well. That's really good thinking though, Peter. Well done. So we've then got this femoral nerve here. If I just zoom in there. Okay, so that's your femoral nerve there. If we go all the way back up, so she may have a problem with her spine. Okay, and we've had this in her history that she's had this problem with her lower back for years and years and years. So it may be that there's some kind of degenerative condition in her back that's causing these problems as well. Okay, so that could potentially be an issue. One of the other things that I think Natalie came up with, which was really good, was to do with this nerve here. Now, this one's the lateral femoral cutaneous nerve, that bit there is your ASIS. That bit there is your pubic tubercle. And between the ASIS and the pubic tubercle, you've got your the ligament. And that ligament is the nerve passes underneath there. So if you are if you're seated quite a lot or wear really tight trousers, like a tight belt around your trousers, then that can pinch on that nerve. And there are other conditions as well that can affect that nerve. Okay, something that some of you have picked up on. So we'll do that in a sec. So this nerve here, this isn't a motor nerve. This is a purely sensory nerve. So what this nerve does is supplies the feeling to the outside of your thigh. So if I just zoom out there, so see all that purple area there. So if you've got symptoms down the outside of your, what looks like your quad, so around the vastus lateralis area, and it just feels weird, it could be the lateral cutaneous nerve as well. Okay, so that's another one to add on to the differentials. Okay, so it may not be a muscle issue. It may be something to do with the blood supply or the nerve supply. Let's just start that up again. Okay, so quick recap of anatomy, and then let's have a look at these. So feet and lower back symptoms are worse first thing in the morning. Okay, seems to be pain on walking. Now, that is your typical plantar fasciitis. Yeah, so they may be completely unrelated. The feet problem or the feet problems might be completely unrelated to the problem with the quads, or they could be linked. Yeah, so we need to kind of work out, is it linked, is it not? And I don't know whether we ever would with this person. We need to send them away for testing. So there seems to be pain on walking, especially after resting. That's classic plantar fasciopathy again. Okay, so if you sit down for a while and then you get back up again, the plantar fascia hurts just underneath the heel. And but also we've got for both feet and the thighs. Yeah, so plantar fasciopathy wouldn't affect the thighs. It may change your gait, which may affect biomechanically the quadricep muscles. But if you've rested, so your muscles don't need blood, and then you're active, so they do, the muscles will feel tired. Okay, they'll feel weak when you start to walk. Yeah. So if you've rested for a while and then go to get up, obviously those big muscles need a lot of blood. And if they're not getting them, then the muscles will feel tired. All right. So again, something to think about. And walking's becoming more difficult, causing more pain. Pain in the quadriceps muscle seems to be more intense and of a burning quality on walking upstairs. Okay. Anna tells you that it feels very hard to manage getting up the stairs over the last few weeks. Okay. So there's a big clue. Okay. So we've got an issue with the potentially with the blood supply there. Okay. So we've got numbness in the feet. Let's just go back back a few. So numbness in the feet, and then within her history, we've got her just here living on chocolate bars and sweets. Cool. Yeah. So burning pain can either be neurological, is usually neurological, or blood supply. Okay, so it's usually a blood supply issue or neurological. And this is the thing with this case, it's a bit crossed. Yeah, so there's a bit saying that it might be blood supply, but then there's a bit saying that it might be plantar fasciopathy. And this is the thing, you have to kind of weigh it up. Is it one or the other? At the moment, we've no idea. Okay, because we'd need to test. So yeah, a couple of you picked up with the diet because she living on chocolate bars and sweets and not very healthy at all. The other reason why you might get numbness in the feet is a peripheral neuropathy. So peripheral means towards the outside. Okay, so hands and feet, and a neuropathy is where there's a loss of sensation. There's a problem with the nerves, basically a kind of nerve problem, if you like. And diabetics will often have a peripheral neuropathy. So their feet and their hands will usually be affected. Okay. They call it like a stocking and glove symptoms. So they lose sensation in the fingers, lose sensation in the toes. That's why with if you've got severe diabetes, then you need to have your toenails cut by a podiatrist, because if you cut your own toenails, you can't feel yourself cutting your own feet. Okay, so you can cause yourself some real problems with advanced diabetes. So that might be an issue as well. Okay, so if we skip through, so yeah, feet and legs gradually worsening over time, and then lower back 2 to 3 episodes a year. And a few of you picked up potentially that's come from changes in the biomechanics of the pelvis from childbirth. Okay, and we can surmise that. We have no idea because she's 62 now, and I'm imagining her children. Well, I think it said her children are grown up, so that would have been a long time ago. And yes, we can attribute it to that, but we wouldn't know for sure. Okay, so it would be something that we could pin it on that potentially. So examinations of treatment, right? She's not been to the GP for years, and that's a problem. Yeah. And this will also change, potentially from epidural. Yeah. Again, it's one of those things where, we would surmise, okay, we wouldn't know whether it's had any long-term effect, because I mean 40 years ago a lot has happened since then. Okay, so we could attribute it to those kind of things, but it would be trying to fit your thoughts into a story to make sense of it, and sometimes it doesn't make sense. That is potentially a good story, but we've no idea whether that's the truth or not. Yeah, so we could surmise that, but it might not be the case. I think that this one here with the GP, this will change how you would approach this lady. Okay, because if she's been told off by the GP for smoking and then she's never gone back, if you then take over this case, you've got to be really careful with how you deal with this person, because if you need to work with them, because if you tell them what to do, they're not going to do it, and then they're not going to come back. So if you really want to help this person, you need to tap into their psychology about what is meaningful to them, what would they be able to do. I mean, obviously we're talking that if you could treat them, at the moment it's not looking likely, but if you could, and if you could work with them, things like that are a big yellow flag. So we've got these psychosocial issues which may affect her recovery. And that's something that you've got to really think about. She suffered from urine reurgency for a year, and stress incontinence. And now we've got a change in we've got a change in bladder habits. Exactly. So not tell her she needs to change her diet. Good. So I mean, the thing is, right, most people know what a good healthy diet is. And we choose to eat rubbish. And there are certain triggers that if you just tell people, oh, you just need to do this, that they know what to do. They're not doing it though. So and if you're not for me, I've got a dietitian that works with me. So I don't even go down that route. I forward them onto our dietitian because she's an expert in managing people like that. And I think that's a real good point with this as well. You need to know your limits of your expertise, and that for me is not something that I deal with. Our dietitian works with our CBT therapist, with people with eating disorders. But then what you've got to be careful of is approaching that subject and saying, oh, I think you need to see our dietitian, because then if there's, so, well, why do you think that? So it's got to be something that you try and get them to come up with. So what kind of things do you think you need to help you make better nutritional choices? And, so wording it in a question so that they know the answer, and then they come up with the answer themselves. It's really, really tough to do. This one here, this is an important one, I think, because we've got a change in bladder habits and we've got lower back pain. So that's a red flag for a cauda equina straight away. So that one there is a biggie, and it's kind of like stuck in there, and you forget about everything. You forget about this because of everything else that's going on, but she's got changes in her bladder habits there, and that with the back pain, that's not a good sign. So she's had several episodes of thrush. Now, thrush is really common if you have a high sugar diet. So again, we've got that kind of diabetic. And diabetics will suffer more so from thrush. So we've got we've got these problems that if the blood sugars are uncontrolled. So again, we've got these things that are pointing towards possible diabetes there. This is an interesting one, so I'm going to leave this one for you as a bit of a task for Friday. So her mother had a skin complaint for years, but she can't remember what it was. But she knew that she took prednisone. So that's going to be a little bit of homework for you guys for Friday to work out what could that condition have been, and what prednisone is for, and what the so then we can possibly link, is Anna's condition linked to her mother's? And then again, we've got this alcohol, a lot of alcohol, so maybe liver problems, which you picked up, which was good, plus the poor diet again. So that's been mentioned again. So that's a bit more in depth on the case, and kind of leading you down a few pathways. So this is the list that we've got so far. These are some of the things that you guys came up with. Yeah, really good. Yeah, dermatomyositis. Yeah, really good. Now we're getting somewhere. Cool. Well done, Nicola. These kind of things, the blue ones, are ones that you guys came up with. So that's really, really good. So what I'd like you to do is, and I know some of you have already done this, but if you haven't seen these, then it's worth having a look. So why did you choose peripheral arterial disease? Why did you choose compression fracture? So on and so on. And then these are some of the things that I put in. So we've got a condition called polymyositis. which may be linked to this dermatomyositis. Okay, so have a look at that. And then femoral nerve tension. Okay, so because we're getting this sensation down the front of the thigh, it could just be nerve tension. Okay, we'll have a look at how to test that on Friday. Okay, so those are our, or that is our clinical impressions so far. What you would then do is pick your top 3. So you go, right, okay, this is number 1, what I think it might be. This is number 2, this is number 3. And if there are any red flags, then you would get them off and you would refer them. Okay, so that is the right-hand column, the next step. So what I'd like you to have a go at, I'll do it myself for Friday as well, and we'll see what you guys come up with too. So similar to the previous weeks. So you can add more to the clinical impression. Yeah, the list is endless with this one, but you need to justify it again. Okay, so Nicola, same for you. Yeah, so with the dermatomyositis, really good. But if you pop on the Facebook page why you think that, okay, that would be really good. And then these are your tasks. So fill in the whys. Okay, justification. What is prednisone and what is it used for? Okay, so not just in this case, but in general, what kind of conditions is it used for? What investigations tests would you expect for the conditions listed? Oh, cool. Oh, well done. Brilliant. Thanks, Nicola. Brilliant. How would the psychosocial elements of the case impact your plan? So we talked about that a little bit today. So have a go at thinking about that. What if you could treat this lady? What would you do? What would you have to be mindful of? What other services might you use? That kind of thing. Okay, and then we'll have a look at those on Friday. If you want to pop them on our Facebook page again, and at MTE CPD, if you type that in the Facebook bar, the search bar on Facebook, it will come up. But again, if you don't want to post it, you want to send them to me, then I'll do it on your behalf. Okay, so that's the plan between now and Friday. So I will see you on Friday at 6 o'clock. See you then.